Nisa Mbulavinaka, ke Rovi Talnotingo, ke Dr. Zoe Irvine. Maramani Valangi, Punoi Tiko mai na Ingo na Wellington, Porua, Sonangona Kapiti, Sonangona Wellington, Kerona Vitalnoa, and a Sona Veka, and a Talno Taho, o Dr. Zoe Irvine, and a Nonangande Kitonga, Kena Sotal Naka, e reida toko me baleti kenda na Pacifica and the Samai Tungo i Aotearoa. Dr. Zoe, I've just mentioned that you are a doctor here in Wellington, and you've just returned from your trip in Tonga, and would love to hear some of your thoughts about your trip, and also anything that is pertinent that we need to know as Pacific people in Wellington.
Thank you. We visited my stepfather in Tonga, Ned Cook, and if listeners possibly could just Google him to find out more about the work he's doing over there.
What's his name again?
Ned Cook.
Ned Cook.
Yep.
That's your stepdad.
Yeah, and worth knowing about. I'll talk about what I'm doing, which is working as a GP, and I've just come back to general practice this year after about 15 years working in accident and medical clinics, and one of the common interests that I have with Elisapeci is the way that we code for ethnicity in healthcare. My own experiences just as a doctor is always trying to keep up with the new technology, and an example of that now I've found coming back to work in general practice, one of the things that's new is that we can text patients from our keyboard. So there's an icon on the screen that if we click on that we can type in a message and a text goes out to the patient, and so that's given me every time I have a few moments spare, I'm thinking I really want to text all my patients and say things like, are you taking those gout medicines? That gout is damaging your joints, or have you quit smoking yet? Or and just the general advice, soft drinks are the devil's juice. Don't drink fizzy drink, And I don't think patients really want to be getting those sort of texts from their doctor every 10 minutes. So I'm very I'm careful not to abuse that feature, but there's a lot of new features coming out in the software. One of the things that isn't new is that when you enrol with a doctor, you tick a box or fill in a form to say what your ethnicity is. And so when you see a doctor, that's up on the screen along with your name and age and address, and then we've got your ethnicity. And that's something that I look at quite a lot. I think I've spoken to Elisapeci about how we probably, look at that part of the screen more often than you realise as patients, even for treating something as simple as a sore throat. The guidelines for giving antibiotics, or doing a throat swab and waiting for results, or telling people that they don't need any investigations or treatment, are determined by your age, where you live, and your ethnicity. And so you would often, for the very common things such as a sore throat, you would have a look at that box and see, what's their ethnicity, and you'd factor that in. So the Fijian and Indo-Fijian coding is something that has been a common interest to us because there is, as Elisapeci has said, a loss of collating data for Fijian peoples in New Zealand, and that is for both the Indigenous Fijian peoples and the Indo-Fijian peoples, because we simply don't know when someone ticks a box what the factors were that chose them to tick one or another, and I would never ask. It's a very, very personal question, and I think as a doctor, you're already asking people very personal questions about, have they ever had, how many pregnancies, and did they continue them, or how many partners have they had? So you're asking people these very, very personal questions already, but to ask someone why they had chosen a particular ethnicity or is something even more personal, I think, and but it does make a difference on a level of how we. It may make a difference to the treatment you receive. Whether even for something as simple as whether you get antibiotics for a sore throat, because it's a demographic risk factor for rheumatic fever, for example, to be Pacific, and so there's that whole area where I think it's really good to start a conversation around ethnicity coding, and I'd get back to Elisapeci. What would you say?
I'm quite interested in your thoughts about ethnicity coding, because in the 2006 census, that was well before the legislation change in Fiji on nationalities. And then we look at the stats in New Zealand in 2013, and you see a big hike of ethnicity, Fijian ethnicity numbers, particularly in the health stats, the figures that are showing in the health education, but particularly for health. And when you look closer at that, it's not all indigenous Fijians. There are other people ticking the box because they've either misread, misunderstood the question. I don't know. So that's an area that I think, Dr. Zoe, you and the team at the data forum that we attended last year, I think, or 2 years ago, and where this conversation has developed, needs to be looked at closely, because if I'm to go back to the community, as we're doing today, we're recording your thoughts as a doctor, medical doctor, for the reason that we can go back to the community and talk about how can we bring down our numbers in terms of illnesses and the kind of sickness that we do present to you as doctors. The only way we could do that really realistically is knowing our numbers, knowing how we are impacting those graphs. So that's probably where I'm sitting at here, but with your thoughts on it, it'll help us understand it more, because you sit there and you see patient coming in and they're ticking a box, and you're probably asking some questions too.
Yeah, I wouldn't ask someone why they ticked a particular box, because somehow I've a sense, and it's been my experience, that that's an even more personal question than asking them about, like I said earlier, how many pregnancies they've had or how many partners they've had, or it's a very
personal.
It's a very personal thing, and it's something that they rightly choose for themselves. And I think most practices are very careful in making sure the person does choose for themselves, and that it's not a box that the receptionist ticks on their behalf, and that they have that absolute right to choose their own ethnicity. But I think it's important from our perspective that it's an informed choice, and that they understand what happens to that data, who's using it, and what we're using it for. And I think I don't have, and I remember the Data Future Forum where we met, there were a number of issues apart from ethnicity data that came up, and interestingly some of them have since gotten quite a lot of media attention. There was the discussion at that time of Aranga Tamariki using a Māori name, and the question of whether they were really working in the interest of Māori families. And I think that was a separate issue that has since gained
generated
attention, and
gained traction.
These are quite difficult topics,
and
I don't have a particularly expert view of them, but I do have experience with being one of the people that uses the data and has pulled on the patient management software, has spent some time doing audits and pulling ethnicity data from large databases, and so and that's with one particular type of software that's used in most general practices. Some general practices are now using a new type of patient software, and I don't know how that codes for ethnicity. And then the hospital has their own software. But I think it would be good to be part of the conversation just as someone who knows how that information is used in practice, and how that differs in some cases as to how it's used in theory.
Yes. Yeah, I think it does, because you're a researcher and I'm a researcher. It does border on, is it fraud that I'm ticking a box that I don't have, my DNA doesn't even fall under that category, yet I'm ticking? Could I tick the box of being a European when I don't even have a single DNA in me? That question also pops up. And like you rightfully said, it's a topic for continuing conversation so that we can capture correct.
From our perspective, you can tick any box that you want, and you can tick a different box when you come back next time, and you can tick a different box on the census, and a different box at your GP, and a different box at the school, and a different box at the hospital, and that's not poor quality ethnicity data. That's just real life ethnicity data, because people do identify with more than one ethnic group, and that might change between situations, and it might change over time.
Even without any DNA in them? I'm choosing something that I don't. Ethnicity is like language. For me, that's a marker. Your language, your food. In New Zealand, the way I look at it, the society you move in, the social structure, if the health, like yourself, are coming to talk to us, we'll send out emails to all our Indigenous Fijians in Wellington because we are inviting you to come and talk to us. And often you'll only find us there, no one else. So our view tend to be constrained within that scope, that if you are going to take Fijian, then you better come to our event, then you better speak our language, you better eat our food, you better be part of us in the social structure. That's the part that I think most of us don't understand.
I think, though, that social structure and those identities change over time, and they might depend on who you're married to, or if you have been adopted, or if you adopt children, or who your family is. And
it becomes wider.
It will, for people, they will identify with more than one group, and they may identify with one group in one setting and another group in another setting, or and that's and I think that if you're not working, it might look from a distance like a complete mess, and you think, how can you make any sense of this? But it's not there to be made sense of. It's there to reflect the real world, and the real world is not. Ethnicity is. A good example that I would give is like a pathologist when they look at a cell under the microscope, and they might say, well, this is cancer, or this is completely benign, and then another pathologist could say, no, what you're looking at is artifact. It's something. An artifact is something that's only there because of. It's only there because of. It's artificial. It's not a real thing. And then the answer to that is, for example, if you're looking at a piece of someone's kidney. Of course it's artifact. You're not looking at a real kidney, you're looking at something that's been cut out and frozen and sliced thinly and stained and put under a microscope. Everything that you see is artifact. And I think for me, when I look at ethnicity data, I do get that sense that everything is artifact. It's all a result, it's a box you've ticked in a certain place. It's a measurement made at a point in time. It was, perhaps a day that you really felt like you were wanted to identify with a particular group or didn't, and that might change the next day. It's all artifact, but at the same time, it's still very important. That doesn't take away any of the significance or the meaning. It's artifact on a lot of levels, in that it's like I said, it was a measurement made at a point of time, like doing a blood test on a certain day at a certain time, or taking someone's blood pressure. That might change, but it could still be very important. And then the ethnic groups that people identify with, I think we've had this discussion that they're not determined necessarily by your DNA, but that they're determined by cultural movements and wars and migrations, and even Māori as an ethnic group, you could argue that that's a European invention, because before the Māori came to New Zealand, before the Europeans came to New Zealand, the Māori were a tribal people and wouldn't have identified themselves as a single ethnic group. So you could say, even in
Ethnic.
some sense, it's not in any sense to say that Māori health is meaningless or unimportant, but in some sense there's a artifact to the calling Māori a single ethnic group, and that whole identity. And you could say that was something that's been created by the Europeans. And I had an Australian cousin, and I asked him, I said to him, well, what ethnicity do you put on your... and he said, I'm Australian, and I didn't understand. I said, but you're white, don't you put that you're, do you have, what's the equivalent in Australia of being Pākehā? And he said there isn't one, because in Australia, to be white Australian is to be Australian. He said the Aboriginal peoples were a tribal people, like in New Zealand. They weren't even considered human until the 1950s. And he said the white people have been in Australia for longer than that. And he said, the first Chinese were in Australia 4 years after the first Europeans, but they are Chinese Australians, and the white Australians are white Australians. And he was quite ashamed of this, but he just said, the way that we create ethnicity categories reflects our society, and it reflects wars and migrations, and as much as anything else. So I think
ethnicity is a problem word.
It's a very personal and
problem word.
I don't know about a problem word, but I think and these are all my ideas more than some of them I think are academic theories, but some of them are just my analogies as a doctor on how I try to understand something that I know is very complicated and that I know is very personal to people. It's it's something that I wouldn't question, and have learned not to say to people, why did you put that ethnicity, when they don't look like that ethnicity? Because it's very, because I know that whatever they've put is the right answer, and it does make the data very difficult to interpret, but it doesn't make it wrong. It just makes it just means that the reality is actually very difficult to interpret, if that makes sense.
Yeah, I remembered you sharing an article, an American article, about this white lady in America, Caucasian, that her father remarried and married a black woman, and they had children. She was the eldest sibling, and she identified with the half black, half white, because she felt for them. They were being victimized in school, they were being treated badly, and so she went through life identifying as a black woman, and then she got taken to court.
There was, I think she
for fraudulent.
She identified as a black woman, and then there may have been some argument on her part that if you can identify as, if your gender is self-identified, why can't your race be self-identified? But America is slightly different again, because there is a conversation about race that we don't have in New Zealand. So
it got subdued.
Yeah, we don't, because New Zealanders don't talk about race. They talk about racism, but they don't talk about...
Use the word race.
They don't use the word race. So in America, and I think I've sent you this as well, there are 5 races, and they are white, which is not white-skinned, but it's just, if you're not in any of the other categories, there is black, which is black African, there is Pacific, and there is Asian, which is Indian and Chinese.
Indonesia.
And so there's a whole, and then a lot of Americans would identify as Hispanic, but that's not Hispanic is not considered a race. Hispanic is considered an ethnicity. So there's a whole other way of thinking about ethnicity, and I don't think that being white in America is an ethnicity. Being white in America is your race.
Okay.
And so the words have slightly different meanings.
Yes.
And they've now got a lot of issues with their census because they've got the citizenship question, which is likely to undercount the Hispanics. And so that's got political implications. And so they've got a big discussion now about their census, which is interesting because they're making their point that actually these things really do matter. The boxes that you tick do matter because they determine where your funding goes and where your
and the treatment.
Yeah, and your treatment and everything to do with schools and hospitals and prisons is all based on the census data. And so if you undercount a particular group, for example Hispanics, then they lose
funding,
a huge amount of resources and political voice. So that's America.
In New Zealand?
In New Zealand, we have something called the population-based funding formula, and this means that so a certain amount of money is allocated to vote health, taxpayer money is allocated to vote health, and that's given to hospitals, and the amount given to each area is calculated on a formula which is based on the age, and the ethnicity of the people in that particular district. So there's Wellington, there's the Hutt, and there's Kapiti, for example, and the amount of money given to Wellington Hospital would be perhaps $1,000 per person, and the amount of money given to Hutt Hospital would be it's slightly more than that, I think, for some reason, and that's based on the funding formula looking at the demographics of the people living in that area, and that is based on ethnicity data. So in New Zealand, the amount of money your district health board gets depends, at least in part, on what ethnicity boxes people tick. Because
so for Pacifica?
Yeah, I think women of childbearing age will get a certain extra amount of funding because they do, with having babies, they do use more resources, and Māori and Pacific. So that affects particularly places like Northland. If they have a large Māori population that don't fill the census in, then they get less money and they are relatively underfunded. It's a bit more complicated because every DHB thinks that they don't get enough money for their. Every DHB is thinking, we don't get as much money as the other DHBs or as much as we need, and so there's always a competition. But ethnicity data is kind of baked into the health funding system in a way that it isn't in other countries. Some other countries do this, and I couldn't tell you off the top of my head, but I don't think they do. In the UK, for example, I don't think ethnicity is used to allocate health funding in the same way as it does in New Zealand. It's certainly for obvious reasons it wouldn't be Māori Pacific or non-Māori non-Pacific would be the categories. So it is. It's important to health in that sense. Because I'm not the CEO of a district health board, it is to some extent not my problem if the DHB doesn't get enough money. But then I will find myself working in services where I think, gee, this place could do with some more money, and if you track that back, you might find that it's part of that the DHB simply hasn't been given enough money to cover this, and that if they and the population-based funding form will come into that discussion at some point. So that the formula, those are the main factors, and then it's adjusted for rural areas, get slightly more, and I think rural areas is the other criteria.
You did
but
serve in the...
People do get a different amount of money per head of population, depending on ethnicity data from that population.
Okay. You did serve in the sub-regional strategic Pacific Health group.
I was on that committee for 3 years. Yeah.
So in your experience dealing with the Pacific segment, because you were there as a doctor, and you had few people that were from the community and a few that are doctors, do you have any reflection on what struck you as to how the Pacific people approach health and how we can help doctors improve health?
I think what happened in the meeting, we were told, is confidential, so I can't say anything
Divulge.
that would look like I was talking about what happened in those meetings. But I did talk to outside the meetings. I did have conversations with one of the committee members about how it would be good that for Pacific people to know that what their data is used for, so that they understand when they tick a box. I mean, they don't. You can tick whatever box you want, and nobody's going to say it's the wrong box. That's the bottom line. It is totally self-identified, and I think the moment we start to tell people what ethnicity box they should tick, it will be the last data that we ever get. It's something that, but I think for people to ask questions and sort of to know, when they tick a box or don't tick a box, where that information goes and what it's being used for, that's helpful, because I think if they're not represented, then the services that look after them don't get the funding ultimately, and that's for complicated reasons to do with the way that the health system in New Zealand is funded under the population-based funding formula, and so to ask questions and to talk as a community, I think, as the Fijians are doing, about what they want from the system and how they want their information to be used. And I think, because you particularly interested in Fijian children's health, have been asking for that information and finding it quite difficult to get, because of the problems with the coding for Fijian versus Indo-Fijian versus Indian, and then and I think from a researcher's point of view, that often just becomes too difficult, and the easiest thing to do is just to exclude Fijians from research, because they know when they're looking at, for example, perhaps they're looking at gout or asthma in New Zealand Fijians, but if they look at the code Fijian, that doesn't tell them whether someone is Indo-Fijian or Indigenous Fijian, and there might be a difference in demographics that they want to look at. It also doesn't. It also doesn't include all of the diaspora from Fiji, because some of them may have identified as Indian, and then so if their data is going to be that confusing and difficult to interpret, it's probably easier just to
abandon,
to limit it to Tongan, Samoan, Tokelauan, and so you but I think you've been asking questions about, well, where is the data on Indigenous Fijian children and hospital admission, because this is my community and these are our children, and so I think it's really helpful for people to asking those sort of questions, and asking the DHB and asking their doctors and saying, well, what data do you have for our
Yeah.
Community, and how do you use it, and how careful are you with coding it and those sort of questions.
That's great.
And also making sure, I mean, it sounds like a really simple thing, but there was a time when I think it was acceptable for a receptionist to tick an ethnicity box.
Not now.
To look at a person, or to assume that because the rest of someone's family is Tongan, they'll tick Tongan on that person. But I think the only way that the data can be wrong is if somebody else has ticked that box on your behalf. So I think from our perspective as doctors, people need to actually tick the box themselves or leave it blank or something like that. And so don't let anyone else tick your ethnicity for you. You can tick a different box every time you come if you want to, but it's something that you identify with. It's not something that
someone's put it there.
It's not something that someone's ticked on your behalf at reception. If that makes sense.
One of the things that we've noticed since we've began the conversation on coding, ethnicity coding, that all of a sudden suicide in the Pacific, the numbers in the Fijian indigenous, I'm not sure because it's tagged Fijian, we have a highest number amongst the Pacific. And that's a big worry. And when we try and ask, because we as community leaders and workers, we want to go out and help our people. If suicide is prevalent, we want to reduce it. But then they can't give us. No one can give us and point us to the direction. This is the quota for Indigenous, and this is the quota for Indians that are ticking the same box and are committing suicide. We don't know.
I don't know. I mean, I think the other thing is that if you look at the way the coding is done, there's levels of coding. So at the most detailed level, you might be from Puerto Rico, or you might be from Spain, or you might be from Tonga, and then at the next level up, you might be from the Pacific, or you might be from Europe. And then I think at the top level, so there's 4 basic levels, and so then there's the question, if you tick Fijian, then that's collated as Pacific.
Yep.
If you tick Indian, then that's collated as Asian. If you tick Indo-Fijian, I can't even remember whether that goes into the Pacific or that goes into the Asian. I should know, but I've forgotten.
But it's something that we can look
at. There's all those
at.
sort of questions as to because we don't need data on every French person in New Zealand, for example. They just get put together with all of the. Well, I might get arguments from French people. There's just not a huge number of them. They just get put together into the European. Classification, and I think it's the same with the Fijian, Indian, and Indo-Fijian.